So our next presenters come from Edinburgh, again in the UK, and the subject is hypertension and its complications in a young man with autoimmune disease, and the case will be presented by Miller-Hodges, and we've got some discussants including Dr. Neeraj Dhaun. So thank you very much.
Thank you very much. Good morning, ladies and gentlemen. I'd like to just start off by apologising to you for the way I'm dressed. My colleague and I arrived from Edinburgh late last night, and not only was our flight delayed, but my luggage didn't arrive, so I'm afraid I've been restricted to having a toothbrush here. So we're going to phase shift slightly to hopefully as equally an elegant organ, the kidney, and I'm going to hand over to my colleague Eve Miller-Hodges to start off the case.
So good morning, everyone. Many thanks for inviting us to present our case today. It's slightly different from the previous case, very much more clinical and a lot more audience participation required, so we're looking forward to lots of suggestions from everybody here. Our case is entitled Hypertension and its Complications in a Young Man with Autoimmune Disease. And the case is based around a young man, 30 years old, who'd recently moved to the UK from Pakistan. He had a recent diagnosis of systemic lupus erythematosus and was originally presented to the rheumatology clinic with joint pain, skin rash, and pleuritic chest pain. His immunology at that time was in keeping with active lupus. He was hypercomplementemic. He had positive anti-double-stranded DNA and positive ENA, no evidence of antiphospholipid syndrome immunologically, normal platelets, and he was lymphopenic. He was rapidly referred to the renal clinic as he had very obvious nephrotic syndrome with a proteinuria of about nearly 4 grams per 24 hours and a low serum albumin. He was actually found to have a pre-existent renal vein thrombosis at that time and was subsequently anticoagulated. And this was attributed to his low serum albumin. His excretory renal function was normal, but he had blood and protein on urine dipstick. And he obviously went on to have a renal biopsy, which showed both proliferative and membranous forms of lupus nephritis. And at this point, his blood pressure was in both American and UK limits, 126 over 88 millimetres of mercury, but on no medications. Although I would point out he's only 30 and he has very heavy proteinuria. For your interest, here's his renal histology. At the top, we've got a lovely normal glomerulus with kind of lacy, delicate capillary network and just a couple of cells in the mesangial spaces. This is our patient's glomerulus. There's thickening of the capillary wall here, and then proliferation in focal areas, but not affecting the whole glomerulus. And so, obviously, our prime concern was treating his underlying disease at this point, and the standard treatments for lupus nephritis would be anti-inflammatory with high-dose glucocorticoids, and then second line, an anti-proliferative agent to deplete T cells and B cells and reduce autoantibody production. And he was treated with pulsed intravenous cyclophosphamide to induce his very active lupus nephritis. But unfortunately, his disease proved very difficult to manage. He only tolerated a very short course of cyclophosphamide because he had an anaphylactoid reaction, probably to the mesna component, which we give to protect the bladder epithelium. We then tried to induce with mycophenolate mofetil, but again, he couldn't tolerate this due to gastrointestinal side effects. 3 months of azathioprine had no effect, and then a further 6 months of an enteric preparation of mycophenolate mofetil, the Myfortic, also had very little effect. And again, he could only tolerate this at a low dose. We finally treated him with rituximab, which is an anti-CD20 monoclonal antibody, again to deplete B cells. But as you can see here, we failed to induce remission of his lupus nephritis, and his renal function deteriorated over the 2 years. And he was also requiring high doses of steroids to continue during that time. His proteinuria remained in the nephrotic range, reaching up to 10 grams a day. And his serum albumin was usually below 20, which is widely accepted as being associated with a higher thrombotic risk. And of note in this, then, he was maintained on warfarin during this time. And I'll just mention now that his warfarin control was actually very difficult. Despite lots of input from both his general practitioner and the renal clinic, then his INR dramatically fell high and low without any real explanation for it. So we've got a young man with ongoing nephrotic syndrome, who's also fluid overloaded and is now becoming hypertensive. And this is the bit that you're probably more interested in. So we'll go back to the first 6 months that we saw him. His renal function is normal at this point, but his blood pressure rose rapidly. And by month 5, it's 174 over 110 millimetres of mercury on no treatment. His investigations at that time confirm his normal renal function, normal electrolytes. His inflammatory markers are in keeping with lupus. He's still hypoalbuminemic, and his lipids, again, are in keeping with his nephrotic syndrome. So I'll just hand over to Bean now.
Okay, so this is the audience bit. So we're going to start off with some rather straightforward questions. So this is a young chap with nephrotic syndrome, so he's not very happy, he's got lupus and he's becoming hypertensive. So my questions to you are listed here. So why is he hypertensive? What are the contributing factors here? And how might you manage his hypertension? And finally, what is it you're trying to achieve here? Over to you.
This is an easy one to start off with, so there must be some suggestions.
Right.
Oh, no.
Sadly, you need to...
Yeah, we have people leaving the room.
I know.
That's always a bad sign. Maybe you need to get started to get things moving.
So why don't I just tell you that in terms of, I mean, this is a young man. He is recently arrived in the UK and he's got renal impairment. So the renal impairment will definitely be contributing to his hypertension. He's also not Caucasian, which is a risk factor for hypertension. And his lifestyle in terms of what he ate, so he had a very high salt diet. He ate lots of chapatis, he ate lots of curry, to which salt was added. And so that contributed probably also to his hypertension. Eve, I'm going to hand over to you.
And more specific to his case was his background of autoimmune disease, and this is really the thrust of this case presentation today. So in common with a lot of autoimmune diseases, he had ongoing systemic inflammation, he was on high-dose corticosteroids, and he also had nephrotic syndrome. But more specific to lupus, which is an independent risk factor for hypertension with any presence of renal disease. And the reasons behind this is that circulating autoantibodies are thought to contribute directly to immune complex-mediated endothelial damage. There's direct endothelium 1 activation, and there's also activation of the renin-angiotensin system. And out with his proteinuric renal disease, these will all be contributing to his hypertension. In combination, all of these things lead to premature atherosclerosis and arterial stiffness.
So based on that, anybody want to suggest some management strategies for his hypertension? So RAS blockers, okay, so we could give him an ACE inhibitor or an angiotensin receptor blocker. In isolation or combination?
Can you come to the microphone? The whole fun is for people to come to the microphone.
Sorry, yes.
We'd probably start with the ACE inhibitor. That's,
okay.
30 years ago, that was used for lupus.
Sure.
And then if that didn't work, I'd probably add an endothelin blocker. I wouldn't combine ACEs and ARBs.
Okay.
At least at first.
Okay, so we have the option of an ACE inhibitor followed by an endothelin blocker. So those drugs are licensed currently for pulmonary hypertension and scleroderma, but we'd be using it off license. Any other suggestions in terms of how to manage his hypertension? Anything more straightforward than pharmacotherapy?
So we talk a lot about the renin-angiotensin system.
Yes.
But rarely try to use the markers of activity. And you could start by measuring a plasma renin activity, which is very high in a scleroderma crisis, for instance. We learned from one of the presentations yesterday that urinary angiotensinogen, which is easily measurable, is increased. And by the way, CellCEP appears to downregulate it. So you could measure angiotensin too.
Okay.
Right? If it's just an idea.
Absolutely. So, so one thing to mention is that this case is from some years ago. The angiotensinogen in the urine might not have been available to us then. Certainly, plasma renin, plasma catecholamines, urinary catecholamines might have been available. I don't know how easy it would have been to interpret them, given he's got renal impairment, proteinuria, he's fluid overloaded, and he's on a mixture of both steroids and other immunosuppressives, as you correctly pointed out.
Yeah, because of the level of blood pressure, most guidelines say he should be starting on 2 drugs at least, right?
Sorry,
and it should be started on 2 drugs. Now, the day before yesterday, I would suggest the second drug, and today I have to suggest a different one because of what I learned yesterday, which is the issue of calcium channel blockers and impaired autoregulation. You know, until now, frankly, I have to confess that ACE inhibitors, a dihydropyridine calcium channel blocker, and a diuretic were like the main skeleton of therapy. But I wonder now, in these people who have already renal disease, whether calcium channel blockers continue being a good idea. And of course, I don't have the answer, but I wanted to bring this up.
So before you sit down, could I ask you, in terms of calcium channel blockers, which class of calcium channel blockers? The predominantly afferently hemodynamic ones, or the predominantly afferent hemodynamic ones, so nifedipine, yeah, or the predominantly efferent hemodynamic ones, such as amlodipine?
You know, I was also surprised by the fact that in the lecture yesterday, there was a mention that the impairment of autoregulation was applicable to both dihydropyridines and non-dihydropyridines. The effect of non-dihydropyridines was identical but less powerful, which is consistent with their hemodynamics being less vasodilator. But the problem was for both.
And I'm going to take the opportunity of you being there to ask you one other question, which is, what would you be trying to achieve here by controlling the blood pressure in this gentleman?
I'm sorry?
What is your target? What are you trying to achieve here? Apart from a lower blood pressure, what are your goals long-term by controlling the blood pressure?
Are you talking about a number?
No. In terms of what is a longer-term goal here?
I mean, you know, the contribution of his blood pressure to progression of renal disease.
Renal disease?
Yeah.
Okay, perfect.
Okay, so this is what we did. We took kind of 4 main elements in managing this, which I think is an appropriate approach to everybody, but also really to target on treating his underlying disease. Obviously, fluid restriction and salt restrictions are important. We still needed to induce remission of his lupus. And actually at this point, and again, I'll just reiterate, this case was from a few years ago, we wanted to offload him and also blockade his renin-angiotensin system. As you've already mentioned, then we're trying both to reduce his proteinuria and preserve his renal function, but also, very importantly, even in such a young man, well, perhaps particularly being such a young man, it was to reduce his cardiovascular risk. This is disproportionately high in lupus anyway. There's an up to 50-fold increased risk of MI in lupus. And he also has a number of extra traditional risk factors apart from that. So this was really a very big part of what we were trying to manage here. And so this is what happened. At 5 to 6 months, we added a renin-angiotensin system blockade. He stopped his own ramipril because it gave him a headache, so he was then started on valsartan, and then a loop diuretic added. And as you can see, this really didn't make very much effect on his blood pressure. And in fact, over the next months to a couple of years, then the addition of 2 further agents, calcium channel blocker and an alpha blocker, really made very little difference at all. And actually, his blood pressures at this point are averaging 160, 170 millimeters of mercury over about 80 to 90. And this is in a man with 5 to 10 grams of proteinuria a day and deteriorating renal function, so someone who you want to prioritize blood pressure control. His investigations at this time show that he's now anemic, which is in keeping with his level of renal dysfunction. He's also got borderline hyperkalemia and again remains inflamed and hypoalbuminemic. And so I'll pass over to Bean to see if we can get some more input for the audience about where to go from there.
So over to you again. So his blood pressure is deteriorating, his renal function is deteriorating. So why is his blood pressure deteriorating, do you think? What factors might be contributing to this?
So one problem is that you haven't managed to control his lupus. He still
Absolutely.
has an active immune disease that is destroying his kidneys, whatever you do. And even if his blood pressure would have been perfect, which is unlikely under the circumstances, you would still have progression of the disease because the kidney is being destroyed.
Absolutely. So as Anna correctly points out, there is this, there is the lupus that is going to be driving, firstly, the renal disease per se, but this is, SLE is by definition a systemic disease. So it will be contributing to the hypertension directly. So one target for hypertension management has to be the underlying cause, that is the lupus. And alongside this, he continues on reasonably high doses of corticosteroids alongside immunosuppression. Sorry.
Can you go back to the drugs again?
The drugs, yeah, sure. There you go.
Okay, so OD means once a day?
Sorry, yes, so OD means once daily.
Okay.
Yeah, once daily.
So what was the potassium?
5.8. Oh, yeah, 5.8.
5.8?
Which?
Well, you know, at the risk of putting myself out there.
And bearing in mind we are nephrologists here.
No, I'm not. But go back to the drugs. Okay, so, I mean, to me, if I know the K is a concern, And I don't know, if you have the new drugs available to manage the K. But first of all, the furosemide once a day in hypertension, to me, is a big mistake, because you're going to get paroxysmal sodium reclamation for a lot of the day. And so if you're going to use furosemide for cost concerns, I'd at least use the BID.
Okay.
Valsartan at 160 once a day, there's a fire going on, and you have a straw to try to put the fire out. While the fire's raging in the back, the patient's blood pressure is elevated. If the patient's on mycophenolate, and I'm not sure if the patient is,
the patient's on mycophenolate.
Why not use diltiazem to reduce the dose of the mycophenolate so that you can save some money and still get better blood pressure control? And the biggest problem I see with diltiazem, and to some extent verapamil, but that's the constipatory concern, is people underdose for diltiazem in hypertension. It comes in a 180, a 240, a 300, but really you need good-sized doses of DILT in this kind of patient. And then as a fourth drug, I'm not sure why you use an alpha blocker before you'd use at least an alpha beta, or if you're going to do it. But I know the K is a concern, and that might be a reason to use a lower dose of the valsartan. But would you consider even spironolactone? Because I think this patient has a lot of salt-induced hypertension. The other thing is, do we have any conception of nighttime blood pressures? Would you consider giving some of these medicines at night instead of just in the morning, or split doses, like I said, of some of them? So I would have approached the blood pressure control differently.
So those are all excellent points. So in response, just broadly, some of the so this chap was managed in the nephrology unit, and so we often tend to focus on the kidney and the lupus before we tend to focus on the blood pressure. So, for example, this chap was nephrotic, and so our valsartan is very much dedicated towards trying to reduce proteinuria. The frusemide once a day, I absolutely agree with you, and that will become apparent later. The frusemide again was probably more directed at fluid overload than it was hypertension. We tend not to, and the other thing to say is that there will be a US-UK divide here, or US-European divide here. So we tend to not use diltiazem for hypertension. We tend to use alpha blockers for hypertension as third or fourth line agents. Yeah, so shall I hand over to you?
So as many of you have identified, then he did have the major thing contributing here is worsening renal impairment, his ongoing proteinuria, and as you rightly identified, salt and water retention. His disease is still active, which is a major player here, and he's also anemic, which is now requiring erythropoietin, which might be contributing. And it's also worth mentioning that adherence was a concern at this point. I'd already touched on his warfarin control was very poor, and although we never actually got him to admit to it, and we certainly didn't test any drug levels because it wasn't really possible at that time, we did worry about whether he was taking his medications, but it will become apparent in the future that, that this was less of a concern. It's worth mentioning now the mechanisms behind nephrotic syndrome and hypertension. Obviously, you're all aware of the underfill versus overfill hypothesis, and it's quite possible that both these mechanisms were contributing here. He remained very hyperalbuminemic, so had lost oncotic pressure due to loss of plasma proteins, and therefore had extracellular volume expansion and intravascular volume depletion, so was therefore holding on to salt and water, as has already been mentioned. However, there's also more recent evidence, mainly direct evidence from animal models, that the protein loss itself causes proteolytic activation of the ENaC channel, therefore directly leading to renal sodium retention. But again, in combination, then I think salt and water retention is a big issue here. So for those of you who did ask for more investigations, there wasn't really any sign of any other end organ damage with a normal echo and normal fundoscopy. And we actually didn't do 24-hour ambulatory blood pressure measurements. As I said, this is from some years ago, so they weren't really available to us then. Although it would have been an excellent data to have had. So he's on an angiotensin receptor blocker, a small dose of loop diuretic, calcium channel blocker, and a small dose of alpha blocker. We've already heard from our colleagues, so I think I'll just move on in the interest of time. What we did, as mentioned, is we combined dual renin-angiotensin system blockade with valsartan and then reintroduced ramipril, but this had to be withdrawn due to hyperkalemia, even though we did try and lower that with correction of his acidosis. We did increase his diuretic to try and offload salt and water, and given the fact that both his lupus and his hypertension weren't really behaving as we thought they would, he underwent a repeat renal biopsy, which showed progression of his underlying disease. As we've mentioned before, then the thrust being trying to manage his inflammatory disease, we underwent a further trial of cyclophosphamide, this time at a low dose and without the mesna component, to try and get on top of his lupus. Again, his renal biopsy shows his old one at the top, and then here is the new one 2 years later. There's now proliferation throughout the glomerulus with gross thickening of the capillary basement membranes and virtually no filtration area left at all, so you can see why his kidney isn't working very well. At this point, he's now suffering from the burden of heavy immunosuppression and had a number of hospital admissions with recurrent infections. His renal function continues to deteriorate, but he's now unable to tolerate any form of renin-angiotensin system blockade due to hyperkalemia. And he's just maintained on lupin thiazide diuretics, a calcium channel blocker, and an alpha blocker.
So just before I ask, the question is, what do you do next here? I just want to raise the point about the spironolactone. So this gentleman has got deteriorating renal function, already has a problem with a tendency towards hyperkalemia on valsartan at suboptimal doses. And so I don't think I would, as a nephrologist, put in spironolactone, especially because his dietary potassium intake in this gentleman, given his lifestyle, would have been quite high. So that would be the reason not for adding in spironolactone. And just going back to the biopsy, when I see this biopsy, to me, any blood pressure or anything becomes down to the kidney. So I see there is no blood going through his glomerulus. So to hypertension, to me, rightly or wrongly, is renally driven. So I would then focus on trying to control his disease, rightly or wrongly. So what would you do next in this gentleman? Yes, sir.
So I like this comment about the plasmin, which is a very new concept, activating the sodium channel. And also because nephrotic syndrome, independent of that, the ones that retain sodium, the site of the retention seems to be the cortical collecting duct and ENaC driven. So that's why focusing on downregulating this aspect with either spironolactone or a amiloride may work for the hypertension, but then you have the worsening of the hyperkalemia. And that's where the new potassium binders may help, right? Here you have patiromer, which is already approved in the United States. You have CS9, that's FDA is studying it. This is the old-fashioned kayexalate, but perhaps that could be a good opportunity to try the patiromer, at least to facilitate the treatment. But I couldn't agree more that this mistake of the once a day furosemide is common practice in the United States. So I see in England it happens too. Thank you.
So the potassium binders weren't available to us then. So and we still can't get them. So actually, the diuretics that we use, it used to be. In fact, I can't remember what we used to use in the old days. But often the diuretic we used to introduce in people who had a tendency towards hyperkalemia with the renin-angiotensin blockers when we wanted to try and maintain the renin-angiotensin blockers. So we used to add in the diuretic to try and increase urinary potassium excretion. But so this is where we are at the moment. What would you do next then in this gentleman? We don't have access to potassium binders.
Because he stole the patiromer from
me.
I'm going to invent something else.
Yeah.
It's not what I would do next, because there are next things to do, but something that would occur to me next, meaning if you've done the three nexts and you're still stuck. You know, lupus is an antibody-mediated disease, but you really cannot exclude that at the current stage of our knowledge, participation of T-cell inflammation. Simply, it might be the hypertension, right? Then if I would have failed all therapies in this patient, and even at the risk of going to jail,
even renal nerve ablation here.
No, No.
No, that's fine.
No, because that we have a randomized clinical trial that's negative. I won't go to jail for that one.
Fine.
But I would go to jail for abatacept, for inhibiting the co-stimulation of T cells, because, you know, it's the draw of the luck. Maybe I don't know what it would do to the lupus. I don't think it would do much because you have a very active process in terms of autoantibodies, but maybe it reduces the blood pressure, who knows?
Yes, so I mean, abatacept is an interesting idea, and the trials for abatacept in terms of renal disease and hypertension were not there then. I mean, I would go back to you and say, well, to me, lupus, whilst there being a T cell mediatory function, it is a B and T cell mediated disease and plasma cell mediated disease. So I would come back to you with probably a B cell co-stimulatory blocker such as belimumab. But going back to this, in terms of drugs, what would you do here? Any ideas? Yes, sir.
Well, what was his pulse?
Good question.
90.
Yeah, yeah. So a lot of these drugs work on volume, and you really have to me, you have very little effective blockade of the renin-angiotensin-aldosterone mechanism. And somehow, I think we've got to work on that. Mm-hmm. So I clearly, if I couldn't because of the potassium, which is really tying my hands, and you're saying that because this is an old case, or because where you practice you don't have patiromer available? So
it's both.
Yeah, we aren't allowed to use potassium binders either.
Okay. So I would at least want to use an alpha beta blocker if you feel strongly about the alpha blocker, or a beta blocker. I would also consider, because of the renal function, I'm not so clear if I could use another loop augmenter. I don't know how bad the renal function and the GFR is now.
Yeah.
I would consider adding diltiazem to the nifedipine. The nifedipine dose, to me, that's a once-a-day long-acting nifedipine.
Correct.
So once again, that's not an industrial dose. And I would feel comfortable going up on that, or clearly unusual, but in these kind of cases, adding DILT to the dihydropyridine, you can get some additional blood pressure. It does work on volume as well. So the higher the salt intake, the more the CCBs are going to lower blood pressure. That's why we don't have viraparetic and diltiazem, because when those studies in cells were done, without controlling sodium, it was hard to see on a sodium load that you had an augmented effect of a viraparetic, etc. So that's what I would do next while you work on the lupus, because I'm not a rheumatologist.
No, that's fine. Although we're nephrologists, we manage it much better than rheumatologists, actually. But and that's great. I'm going to pass over and just make two comments, which actually we didn't include here. I did try, at the time that it was available, aliskiren, so a renin inhibitor, and that was in addition to the valsartan, which we had to stop, and that drove the potassium up. And then aliskiren was not available. And the other thing we did try was I tried short-acting nifedipine, which I think, I must say, giving short-acting nifedipine 2 or 3 times a day, I must say I have had better acute hypotensive effects than long-acting nifedipine. But he suffered really bad headaches with short-acting nifedipine, which is why we had to stop that as well.
Okay.
However, our hands were tied because, unfortunately, events got the better of us, and we weren't able to do anything because then he presented acutely to the accident and emergency department with a headache, seizures, confusion, and agitation. His blood pressure was very high, 240 over 140 millimeters of mercury, although that doesn't seem that high in comparison to the previous case. He was tachycardic but afebrile and with a normal blood glucose. He was intubated and sedated, and his seizures were controlled with intravenous phenytoin. He was still anemic. His CRP was now high, had ongoing impairment of his renal function at a similar level. Electrolytes were normal, and he had an acidosis and a high lactate in keeping with sustained seizure activity. So what's the differential diagnosis here?
We've got some help.
Cheryl Laffin from Vanderbilt. You basically are questioning whether he has lupus, cerebritis versus hypertensive, what we used to call hypertensive encephalopathy, or now PRES.
So I think that's right. So, correct. So I think the question is this, well, I suppose there is a third possibility here. So you have, is this a complication of his lupus? Is this a complication of his hypertension? But I suppose then you also have the two other possibilities that, has he had a stroke? Is there some sort of infection going on here? I'll hand over to you.
And really, the point that we wanted to make is that actually infection is a really big differential here. He's very heavily immunosuppressed, and there's been an acute change in his neurology. So that's probably the most important thing to exclude. But then we're really trying to differentiate between this being a primarily vascular event or whether it's a primarily an autoimmune event either between a cerebral lupus or PRES, as we've discussed. So what's going to help us decide between those things? Can we have any further investigations or imaging that anyone would like? Anything else?
So I'm just going to say we're in the UK, not the US.
We might look at his pupils, at his retina.
So before you'd like an ECG? I'm joking.
We'll look at his retina.
Look at his retina, and if do lumbar puncture maybe.
Using that excellent UK type choice.
Yeah.
Yes.
So we
membership of the Royal College of Physicians.
Yeah.
Well, his GCS at that time was about. So he was obtunded essentially. His GCS was about 11, so he was kind of moving and groaning and wriggling around, but not making any sense.
So back in the old days, if you didn't have papilledema, one might want to do an LP.
Yeah.
Yeah, it's suggested a minute ago.
Yeah, and we could actually have stretched to a CT in the NHS. We put our hands in our purses and did manage a CT. So he had a non-contrast CT, which is shown here. And although it doesn't project very well, the more eagle-eyed amongst you will see that there is some areas of low attenuation in the posterior occipital regions. He did have a lumbar puncture, which was acellular, normal glucose and protein. His viral PCR was negative, and he also had no signs of infection on any other microbiological investigations. And finally, we did stretch to an MRI, which you can see is very abnormal, with these areas of high signal, again, in the posterior occipital regions. So with this in mind, we obviously needed to control his blood pressure. He's still obtunded with blood pressures 240 over 110. Any thoughts about how's the best to do that?
So essentially the question is, how are you going to reduce the blood pressure acutely? Again, there might be a UK-US divide here. We don't use sublingual nifedipine anymore.
Can we get you to the microphone?
Sorry to keep making you walk up.
To me, when the brain is involved in an encephalopathic presentation, nitroprusside is the best drug.
Okay. So sodium nitroprusside. Anything else?
Nitrates?
So intravenous nitrates. Any other class of antihypertensive agent that you might use? Maybe you don't use it in the US, I don't know.
And some people also use labetalol, IV labetalol. Mm.
Yeah, so we tend to use labetalol.
Perhaps even earlier in his course, we used to give people minoxidil.
Yeah.
And their renal function occasionally got substantially better.
Yeah.
I realize might cause fluid retention, but particularly if you're only giving furosemide 80 milligrams once a day, but that might be an option.
Yeah, no, sure. I think minoxidil is actually used more in the US, isn't it, than in the UK, because we rarely use it.
Use it as last line.
Yeah.
It's a last resort.
Yeah.
It's being used much less. Yeah.
Is it?
Yes.
Maybe you have more of an issue with alopecia here, I don't know.
You just have better drugs today. and you have to use a beta blocker and a strong loop diuretic.
Yeah, absolutely.
I wanted to remind you that improvement in GFR with minoxidil is like the early improvement of GFR with amlodipine in AASK.
Nifedipine.
The amlodipine arm of AASK, meaning initially, when you compare with the glomerular filtration goes up, and probably you as nephrologists shouldn't like it.
Well, so we don't like the way that nifedipine improves GFR because the afferent to efferent dilatation. We don't like that because it hurts the kidney.
Especially in him.
Especially, and yeah, it's in someone like this, or diabetics in particular. Okay, so nitrates, beta blockers, and how much do you want to reduce the blood pressure?
Yeah, we want to go to safe levels, not normal levels.
Okay.
Yeah, and slowly, not too fast.
So we kind of cut this in a little bit to catch people out, because although nitroprusside probably is the best drug, then we absolutely cannot use it in this man because of his renal impairments. So the risks of cyanide toxicity are far greater in patients with pre-existing renal impairment. So although it will give the better antihypertensive effect, it works very quickly, it's short-acting. Sorry, the slide's been half-eaten on one side. Then we shouldn't use it in him. And intravenous nitrates or intravenous labetalol are probably the best choice. As we've said, slow reduction in blood pressure is what we're aiming for, partly dependent on the rate of blood pressure rise, although as he's presented from the community, then we don't really know that. Aiming to prevent further vascular injury, but to avoid reducing his blood pressure below the autoregulatory range and therefore precipitating secondary ischemia. And so this is what happened. He was put on intravenous nitrates to start off with, and his blood pressure improved over the first 24 hours exactly as we'd like it to. His conscious level improved, but didn't get completely back to normal. He was still a bit confused. And even with the addition of multiple oral agents, some of which he was on already, and the red ones, some of which were added new, then his blood pressure remained very high over the next few days. And in the end, we ended up adding in adrenergic blockade intravenously as well, still with blood pressures kind of 200 over 100 and without a return to normal neurology. He's still anemic. His CRP is still high. His renal function's a little bit worse than it was before, and he now has low serum sodium and serum potassium. So what further information would you like here? He's not behaving as we'd expect him to. Mm-hmm. Sorry, so yeah, I'll just go through the drugs just so he's on a beta blocker, he's on an ACE inhibitor, he's on lupin thiazide diuretics, big dose of alpha blocker, full dose calcium channel blocker, and a bigger dose of intravenous furosemide twice a day.
The mean arterial pressure went from 200 to 133 in less than a day. 133 is 66%. I'm calculating his mean arterial pressure went from 200, 100 to 250, it's about 200, to 133 on the fourth dot. Yeah. That's about a 33% reduction. Is that right? My math is not very good, sorry. But what I mean is he may be confused because you may have gone below 75% of his starting mean arterial pressure.
I suppose that's a good point. This is so it did drop. He's had kind of 4 days over this rather than it all happening within the first 24 hours, which I suppose would go against that. But
I mean, you know, the safety point, and actually it's a relative safety point because you don't even know whether that blood pressure is his blood pressure that determines the range of the autoregulatory curves, right? But I would say if you go below 75% of the starting blood pressure, you start having hypoperfusion. However, because God knew there were going to be doctors, there is some increased extraction of oxygen. You have a little more safety below that point. But one has to be very careful with that initial day reduction. Yeah.
So we probably were on the borderline for the first 24 hours. However, I do think that we'd probably aim to get it lower in that first 4 days, and that didn't happen. Done that. Okay, so anybody else want any further information at this point?
What's happened to his creatinine?
Oh, sorry.
Function?
Sorry, I skipped over that. So yeah, this is the one, sorry, we went back 2 slides. So his renal function is a bit worse, but his potassium is now low, his sodium's low, he's still inflamed. So this isn't behaving as we'd expect it to.
Okay, we need help.
At least in our ICU, nicardipine is a huge volume when you use it. So he's becoming overly diluted. I can't tell you as a nephrologist what to do about that, but that seems to be part of the problem. Also, is he still on Cytoxan? Because that's...
So he was on oral cyclophosphamide, which has been stopped. He's still on some steroids, and he was on hydrocortisone when he came in a kind of
in terms of
crisis.
blood-brain barrier,
Yeah.
that's the problem as well.
Anybody else? Oh, sorry, wrong way.
Well, I'll take a stab at it, but I mean, I'd like to know in some way his volume status. You've got him on a dual RAS blockade. His renal function has deteriorated from 1.9 to 2.32. So in the risk of being thrown out, at the time this is going on, would a plasma renin and a plasma aldo in any way help, or non-invasive evaluation of cardiac output to peripheral vascular resistance, just to get a better handle? Yeah. I presume the output, the urine output is good?
It's adequate rather than
so,
good. Yeah.
I mean, you need to know which way to go. I'm concerned that he's on the ramipril and the valsartan with renal deterioration at this point.
Yeah. So the only thing I'm going to comment on there is that, so when he presented like this, and he had a drop in hemoglobin as well, and what we'd known was that for some time he'd had uncontrolled lupus. And whilst it probably did fit, or it might have fitted with a hypertensive complication, my worry was with a drop in hemoglobin and active lupus that he was developing another autoimmune complication that was involving the neurological system. And so whether we should consider additional treatments for that. And also whether we should just give up. That's the other thing, whether we should give up on his kidneys. And because we've given him a lot of immunosuppression over a long time, he's now developing he'd had a number of infective complications. And so giving up on his kidneys wouldn't be the worst case scenario, because actually no matter what we do here, he's going to he's going to reach end-stage renal failure within a relative short amount of time within his lifetime, whereby we would consider a transplant. And it might be better for him in the long term to cut our losses here, ditch the immunosuppression, because we know we're going to have to immunosuppress him long term for his transplant.
So in my practice, although I do think plasma renin and plasma aldo has a place when you're 3 drugs in and you're looking at, you could blindly add spironolactone, this is complicated here, or I like the relationship there. When you're on 5 and 6 drugs, and you're just adding drugs because the pressure is not controlled, I think the only time I would consider plasma renin and aldo is further down the line to try to get an understanding of what you've done. Sometimes it's very hard to interpret in the setting of RAS blockade, dual RAS blockade, but I think it can be helpful down the line. We did a study published a number of years ago, and Dr. Lara was part of it, and he was behind it. The only group we found that helped know what to add next was that group. Far down the line, 3 drug in, and then to know that relationship, not when you got it early as a first drug decider, but that's a controversial area. So at the risk of not being thrown out, I think it can be helpful.
Did you want to say something? Yeah.
Thank you. So we've only got a couple of minutes left.
Yes.
We might wrap this up, but this comment would be...
I am Ana Oliveras from Barcelona, Spain. I was wondering because for sure in this patient the first cause of hypertension must be the renal affection by the autoimmune disease, but it should be interesting also to perform a renal ultrasound Doppler just to discard a renovascular disease in this patient with such high hypertension and so difficult to treat. It was performed.
So it's almost as if we planted that question.
So we did do some of these tests. We unfortunately didn't do the renin and aldosterone because we did feel that clinically he was mildly fluid overloaded at this time. We didn't feel that we could interpret them in the context of all the medications that were done, but I think it's a very good point that was raised. He didn't have, his urinary catecholamines were normal. He still has immunological evidence of active lupus. And because we hadn't done these before, then he did have an MRI of his abdomen which didn't show any adrenal masses, and he didn't have any renal artery stenosis. And again, just as you say, this was precipitated because things were behaving not as we anticipated them doing. So what's the diagnosis here? I might just skip over this for
I
time
think if you
reason.
keep
Yeah.
moving now, we'll...
Well,
Yeah.
there was no evidence of infection. His neurology did correspond to the blood pressure, and the radiological appearances were consistent with PRES. But his blood pressure was unusually difficult to manage, and we'd usually expect it to recover quite rapidly, and he had ongoing evidence of active lupus. So we kind of covered both ballparks here by treating both his lupus, and then, as many of you have suggested before, at this point we were in a position to aggressively offload his salt and water and use an aldosterone antagonist. He had high-dose steroid plasma exchange and also was re-treated with MMF, which he'd never had at a full dose before. And as you can see, the diuretic change resulted in an 8 kilogram weight loss, and his blood pressure came down. And he was discharged about 2 weeks later. Neurology was back to normal, but he's still on many, many agents, dual RAS blockade, calcium channel blocker, etc., etc. You can read them all here. But actually, he didn't remain on those for very long. His blood pressure came down to kind of 130, 140 over 80 to 90, and we could rapidly withdraw his diuretics and some of his more centrally acting agents. And by about 6 weeks, he wasn't on very much at all. And at the same time as this, his lupus was melting away, so he had full remission of his nephrotic syndrome within 4 weeks of this acute presentation, with his proteinuria disappearing to about 0.5 grams a day. In keeping with this, his immunology improved and his inflammatory markers went down. And he was discharged in the long term on dual RAS blockade, a beta blocker, as was rightly pointed out earlier, and furosemide twice a day. So we got there in the end. And his renal function stabilised out. He still had quite significant renal impairment, but certainly wasn't getting any worse. A repeat MRI at 6 months showed resolution of the changes that we saw previously. And so we felt this was a diagnosis of posterior reversible encephalopathy syndrome, but in the context of active lupus. His blood pressure was improved by diuresis and offloading of salt and water, aldosterone antagonism, and also the remission of his lupus. And that was probably induced by the combination of plasma exchange and MMF, but also this was 8 months post his rituximab, so there was definitely a B-cell effect still going on there, but it took all of that immunosuppression to get on top of the lupus. I'll just maybe skip over this bit because we're short of time, and really just reiterate that PRES is actually quite a big risk in patients with lupus. They have pre-existent endothelial dysfunction, both because of the immune complex mediated endothelial damage and also because of the cytotoxic drugs, as have been mentioned. And they're also hyperperfusing anyway because of their renal impairment, fluid retention and hypertension. And that creates a perfect storm. And he's the first of a number of patients that we've seen present like this with difficult to control lupus and then end up in a crisis with PRES. So in summary, our patient had posterior reversible encephalopathy syndrome in the context of active lupus. He was managed with blood pressure control, diuresis and treatment of underlying lupus. And we've discussed the treatment of hypertension in the context of an autoimmune disease, management of hypertensive emergencies and PRES. Thank you very much.